and get started, I would like to welcome you today to today's NephCure U on IgA Kidney Disease. My name is Kristen Hood. I am the Executive Director for Research Engagement here at NephCure, and I'll be the moderator of today's educational webinar. In today's webinar, we're going to be cutting through the noise and really getting some of the key facts around IgA nephropathy or IgA kidney disease from an amazing physician speaker, Dr. Sean Barbour. Before I introduce him, I would like to let everyone know we will be offering a Q&A session at the end of this presentation. So stick around, and throughout the presentation, feel free to enter in your questions or comments, even while Dr. Barbour is speaking, so that we can make sure we get to those at the end. We're going to answer as many questions as possible. The recording of this session will be posted to our website, nephcure.org, and it kind of lives underneath the educational programs section. But now to introduce our speaker, Dr. Sean Barbour completed his internal medicine and nephrology training at the University of British Columbia in 2010. And then he did a 3-year glomerulonephritis fellowship and received a Master of Science in Clinical Epidemiology at the University of Toronto. He's been an associate professor with the University of British Columbia since July 2013, and he serves as the medical lead and chair of the British Columbia Renal Glomerulonephritis Committee and the Glomerulonephritis Registry, where he's responsible for health policy and health services related to glomerular diseases in British Columbia. His research focus is on clinical trials and health outcomes and the health services delivery within glomerular disease. He also uses some prediction tools in his research to improve risk stratification of patients who have glomerular disease. He holds multiple peer-reviewed grants, including the Michael Smith Foundation for Health Research, Kidney Foundation of Canada, and the Canadian Institutes of Health Research. So we are so happy that you are here with us today, Dr. Barbour. Thanks so much. We're excited to learn from you today.
Thank you, Kristen, and hello, everyone. So yeah, my name's Sean. I'm from the University of British Columbia. And today, sorry, these are my disclosures by way of transparency. This is an outline for what I'd like to talk about today, and I was given some very specific and relatively technical objectives to meet. So if I don't hit the tone just right, there will be some time for an open question and answer period at the end. So first, let's talk about what is IgA nephropathy. Well, IgA nephropathy stands for immunoglobulin A nephropathy. And so what are immunoglobulins? Well, immunoglobulins are the same thing as antibodies, and these are part of the immune system. And they're actually designed to attack foreign particles and defend your body against foreign particles. I think we've all quite tragically become very aware of antibodies as part of the recent COVID pandemic, because one example of measuring antibodies, for example, is the response, the antibody response to foreign particles as part of a COVID vaccine that we've all been aware of. Now, there are several different subtypes of antibodies, and one subtype are the IgA subtypes, and that's where IgA nephropathy gets its name. So IgA nephropathy occurs when the immune system produces essentially too many abnormal IgA type immune globulins. These then deposit in the glomeruli of the kidney. It results in inflammation and can eventually progress to scarring over time. So your kidney has several million glomeruli. That's shown here on the left. These are the functioning units of your kidney, and they filter blood to eventually produce urine. And this is a normal glomerulus. This is a glomerulus in the middle that occurs when there's too much inflammation as a result of IgA nephropathy. And if you actually stain for IgA antibodies, you can see that they're depositing in the kidneys of people with IgA nephropathy. So how does one develop IgA nephropathy? Well, this is a pretty complicated slide, but the current idea is that it's actually a multi-hit disease process. So it starts off probably with the immune system in the gut, where the cells of the immune system that normally produce these IgA antibodies into the gut, they actually get a bit confused, and they leave the gut and they set up shop in the bone marrow and instead produce these IgA antibodies into the blood. They then form these large complexes that deposit in the kidney, and that kidney injury then results in IgA nephropathy. So how does IgA nephropathy present? Well, the inflammation and the scarring that occurs in the kidney can eventually cause protein loss in the urine, and we call that proteinuria. It can also cause high blood pressure. It can cause blood in the urine, and we call that hematuria. And eventually, over time, in some people, it can cause kidney function decline. So the clinical presentation can be extremely variable. So very commonly, this is an entirely asymptomatic disease in which asymptomatic hematuria or proteinuria, that is blood in the urine or red blood cells in the urine or protein in the urine, are found incidentally on urine tests. Another common presentation would be slowly progressive kidney function decline over time in the context of proteinuria. Now, there are very uncommon presentations, one of which would be a rapid progression of kidney failure or more severe nephrotic syndrome, which is when there's huge amounts of protein in the urine and quite substantial swelling. Now, one unique feature of IgA nephropathy that we don't see in a lot of other diseases is something called synpharyngitic hematuria, which is a very complicated term that basically means within a few days of developing an upper respiratory tract infection or other type infections, you may notice visible blood in the urine. So the urine turns bloody or very dark and tea-colored within a few days of infection. It most commonly self-resolves after a few days, but this is a very unique feature to IgA nephropathy. Now, it turns out the clinical presentation of IgA nephropathy depends very much on the age at which it's diagnosed. So children are more likely to present with the systemic vasculitis version of IgA nephropathy, which we won't talk about today, or to present with these periods of overt blood in the urine. Adults who are diagnosed with IgA nephropathy, though, tend to present with more asymptomatic urine findings or perhaps chronic progressive kidney decline in the context of proteinuria. So how do we diagnose IgA nephropathy? Well, at the current time, it requires a kidney biopsy, and there's really no other way to diagnose IgA nephropathy. Now, there are several advantages to you in terms of undergoing a biopsy. The first, obviously, is it establishes a diagnosis, which is extremely important. But more than that, it also establishes valuable information we can use to determine long-term prognosis. That is, what is the risk of kidney function declining over time? This was originally developed in 2009 using a standardized scoring system on the biopsy called the Oxford NEST-C classification. In 2016, there was an update to this classification where it's now recommended that all kidney biopsies that show IgA nephropathy are reported in a standardized way and report the elements required for the NEST-C score. And the reason for that is that score provides valuable information about the long-term risk of kidney function decline. So how many people develop IgA nephropathy? Well, if you look at the proportion of kidney biopsies that show IgA nephropathy, and you look at that in, for example, kidney biopsy registries around the world, you can see that there are very large geographic differences. So if you look in East Asia, South Asia, the proportion of kidney biopsies that show IgA nephropathy are upwards of close to 50%. Whereas it's more around 20% in Europe and North America, and it's distinctly uncommon in sub-Saharan Africa. Now, this is not the same thing as describing the number of people diagnosed with IgA nephropathy each year, but it does give you some indication that there are very prominent geographic differences in the distribution of the incidence of IgA nephropathy. So why might that be? Well, people that study the genetic risks associated with IgA nephropathy, that is, gene abnormalities that might contribute to developing IgA nephropathy, would acknowledge that gene abnormalities really account for a minority of IgA nephropathy, at most 7 or 8%. But what's very interesting is that the distribution of high-risk genes in the world follow the same geographic distribution as what we see in terms of disease incidence. So the distribution of high-risk genes increase as you go from west to east across Eurasia, and they increase as you go from south to north, which is the same distribution we see in terms of the incidence of disease. Now, as I said, describing the proportion of biopsies that show IgA nephropathy is not the same thing as describing the true incidence of a disease. And it's actually very hard to get good quality population level data on the incidence of glomerular disease around the world. And so I'm going to present some data now that comes from our BCGN registry. And British Columbia is shown here in this map. It's a province on the western side of Canada. In Canada, healthcare is organized and delivered at the provincial level. So all healthcare is relatively self-contained within British Columbia. And we're relatively fortunate that all kidney biopsies in British Columbia are read at one single center in Vancouver by one of 4 different nephropathologists. So we're able to use this unique situation to essentially capture all biopsy-proven cases of glomerular disease since January 2000. And we link that data with other sources of administrative data so that we can study the population level outcomes of people with glomerular disease. And we call that the GN registry. So what I'm going to describe right now is the incidence and prevalence of disease in British Columbia using this mechanism of capturing data at the population level. So if you look at the incidence of IgA nephropathy in British Columbia, it's around 15 to 20 per million population. So what do I mean by incidence? Right now I'm describing the number of people that are newly diagnosed with IgA nephropathy each year. And what you'll notice, it is more common than many of the other kinds of kidney diseases or glomerular diseases, including membranous nephropathy or lupus nephritis. So even in North America, IgA nephropathy is one of the most common causes of glomerular disease. Now, if you extrapolate this data from British Columbia to the United States, which may not be accurate because there might be very significant differences in the background population in BC compared to the US. Nonetheless, if you do that, roughly 7,000 people each year in the United States are newly diagnosed with IgA nephropathy. So what about prevalence? Prevalence is slightly different. Prevalence is the number of people at any one time that are living with IgA nephropathy. And the prevalence is between 200 and 250 per million. This is at least twice what we see in any other glomerular disease. And this is probably because people with IgA nephropathy are diagnosed when they're young, they're quite healthy, they tend to live a long time. And so we see an increased number of people living with IgA nephropathy in our population. And again, if you extrapolate that to the United States, then you would realize that somewhere around 78,000 people in the United States are living in 2018 with IgA nephropathy. So how do we predict disease progression in IgA nephropathy? This is one of the oldest studies to report outcomes in IgA nephropathy. It was published in 1986. And from this study, we got the general adage that around 20% of people with IgA nephropathy will progress to end-stage kidney disease over a 20-year time horizon. The problem with this, though, is that the risk of kidney outcome is extremely variable in IgA nephropathy. So this graph here shows the 5-year risk of a 50% decline in kidney function. And what you can see is that, yeah, the most common risk is around 5 or 10%, but it's extremely variable. Some people are way out here with a higher risk of 30 to 40%, but some people have much lower risk down here at less than 5%. So there's a few problems with this curve. The first is that the 5-year time horizon is probably far too short for most people with IgA nephropathy. The younger people diagnosed with IgA nephropathy are probably far more interested in a 50-year risk rather than a 5-year risk. Nonetheless, we don't necessarily have the data follow up to describe that, so we're left dealing with 5-year risks. But the bigger problem, though, is how do you actually determine what an individual person's risk of disease progression is? If it's so variable, how do we determine for any particular person that's diagnosed with IgA nephropathy whether their risk is low or high or somewhere around the average? Well, we know that proteinuria is a very strong predictor of disease progression. So if you stratify people based on their average proteinuria over time, if proteinuria is maintained very low at less than 1 gram per day, the risk of progression to end-stage kidney disease is quite low. However, if you're sitting back here at the time of biopsy and you've just diagnosed someone with IgA nephropathy, there are several risk factors that you can consider in terms of their long-term risk of having disease progression. You can use, as I mentioned before, the MEST-C histology scores that you get from the kidney biopsy. That's why we require the MEST-C scores to be reported. You can also use demographic features like age, sex, or ethnicity, or you can use measures of kidney function like eGFR or proteinuria and blood pressure. And there are other less proven predictors, such as genetics or biomarkers. But the question becomes, how do you actually combine these together? Any one patient will have multiple different risk factors, and you want to combine them together to generate an individual accurate risk of progression. And our ideal framework would allow us to use predictor variables that are readily available in clinical practice so that you have access to them routinely, that they can be applicable in multiple different ethnic groups, especially considering the large ethnic heterogeneity we see in IgA nephropathy. And we want it to be applied at clinically relevant time points, hopefully with very minimal period of follow-up required before you can generate a predicted risk. So in order to address this, our group worked as part of an international collaboration of investigators who pooled together data from around the world in adults with IgA nephropathy, with the goal to derive and then validate a prediction tool that can be used at the time of biopsy to predict disease progression. This was done as part of the International IgA Nephropathy Network. So our tool was designed to predict a 50% decline in kidney function. And the predictors that are included in the tool are listed here. So we include GFR, blood pressure, and proteinuria at biopsy, age, the MES scores, again, underscoring why it's so important to have good quality biopsy data, prior use of certain medications. And there's actually two tools, one that includes ethnicity as a predictor and one that does not. So there are several different ways you can look at the performance of a prediction tool. But one way is to compare the predicted risk from the tool, which is shown here on the horizontal axis, with the observed risk that you actually see in the people in your cohort, which is shown here on the y-axis. So perfect performance would follow along this 45-degree line, and you can see that these dots are very close to that line, indicating that this tool actually had very good performance in the cohort that we used to develop it. But what about in other cohorts? So we then externally validated the tool in a totally separate cohort and showed again that there was very good performance of this tool. So how do you actually go about using the tool? Well, it's readily available. It's free to access. There's two ways you can access it. One is through the Calculate by QXMD mobile app calculator on any mobile device, or you can access it through the web-based calculator listed here. I would point out, though, that this tool was really designed to be used by physicians. And so if you're going to use this tool, I would suggest you do so in collaboration with your nephrologist, because it will require predictor variables that you may not necessarily have access to, and you would have to get that information from your physician, which would then also help you have a discussion around what the output of the tool actually means. But if you choose to use the tool, you can download it onto the mobile device. You go under glomerulonephritis, and the International IgA Nephropathy Prediction Tool is listed. It will then ask you to enter all of the various predictor variables that are required. You then select the time horizon over which you'd like to predict outcome, and the tool will output the individual risk of progression over your chosen time horizon. Now, since we originally published that tool, other groups have externally validated it in several different cohorts, including from China and Argentina. But one big question that came up is, what about children? So as I mentioned, the original tool was designed to be used in adults. What wasn't known is, can you use it in children with IgA nephropathy? So to answer this question, we used, again, a large international collaboration of investigators around the world who had pediatric data sets in IgA nephropathy. And the goal here was to update the tool so it could be used in children. So the first thing we noticed is that children have a very unique disease trajectory that is different than what we see in adults. So most children, what we have here in this graph is chronological age along the horizontal axis and kidney function along the vertical axis. And what we can see is that kidney function actually tends to increase in most patients with IgA nephropathy when they're children until they're young adolescents, at which point it may decrease over time. And it decreases in a rate that's very similar to what we see in adults, but adults do not have that initial increase in kidney function. So this is a very unique disease trajectory in children. And as a result, we needed to tweak the outcome of the model a little bit to predicting a 30% decline in kidney function instead of a 50% decline. Now this slide is kind of busy, but what it shows is that on the left, if you try to use the adult model without modifying at all, it doesn't really do a very good job at all of predicting outcome in children. And that's probably because children have that very unique trajectory, which is different than what we see in adults. However, we went through a model updating process. So we updated the model, we tweaked it so that it was designed specifically to be used in children and could predict a 30% decline in kidney function. And when we were done, we ended up with a model that actually performed very well in terms of predicting outcome in children, and that's shown here on the right. And again, much like the adult model, the pediatric model can be accessed free of charge through the mobile app calculator or through the web-based calculator. But again, it should really be used in conjunction with your physician. Now, as we'll go through later, most patients with IgA nephropathy will probably be treated with some form of conservative therapy initially on. And what do I mean by that? I mean by blood pressure control or use of RAS blockade and salt restriction. So the question becomes is when you do that over the first 1 or 2 years of treatment, can you actually use the prediction tool to reevaluate risk at some period of time after biopsy? Because the original tool was designed to be used at the time of biopsy. However, you may undergo some form of optimization of your treatment, and then you may want to reevaluate your risk later on. So to do that, we again went back to our international data set. And what we show here on the left is that if you try to use the original tool 1 year later, it doesn't do that great a job. So we're seeing a deviation of this line away from that perfect 45-degree line. However, again, we can tweak the model, and we updated it so that it can be used 1 or 2 years after biopsy. And we get the results here on the right. So now we're getting very good prediction performance using our updated model. And these results are not yet publicly available, but they're pending publication in Kidney International. And once they're published, they will again be available for use in the Calculate by QXMD app or on the website. So they're not quite available yet, but they will be once the study is published. So as a result of this work, the 2021 KDIGO guidelines specifically suggest that in people with IgA nephropathy, you can develop personalized assessment of their risk of progression using clinical data and as well as data from biopsy. And this can be done using the International IgA Nephropathy Prediction Tool. So this is now a formal recommendation as part of the KDIGO guidelines. So another question is, how do we actually monitor disease activity in IgA nephropathy? So if you're being treated with some sort of blood pressure medication or any other medication, and you want to monitor disease activity dynamically over time, how do we do that? So we can look at a reduction in proteinuria. We can look at a stabilization or improvement in kidney function. Some people think that you can look at resolution of hematuria, although this is somewhat controversial. Certainly the gold standard might be improvement of inflammation on repeat kidney biopsies, although I would point out that this is not routinely done in most patients because kidney biopsies are quite invasive and have some risk associated with them. So the Kidney Health Initiative was a collaboration between the American Society of Nephrology and the FDA. And I would venture to argue that their analysis that I'll present here is possibly one of the most influential analyses that really has the potential to improve outcomes of people with IgA nephropathy. And I'll explain why a little bit later in this talk. But what they did was they took individual patient data from all the different clinical trials they could find in IgA nephropathy, and they pooled it all together. And they were trying to look at whether a short-term reduction in proteinuria that is seen as a result of any given treatment is a good marker for a long-term benefit that treatment might have on kidney function. So that's what they did here. So they pooled all the data from the different clinical trials. And here on the horizontal axis, we have the reduction in proteinuria that occurs on by any given treatment. And on the vertical axis, we have the reduction in kidney progression, which here is measured as essentially a 50% decline in kidney function. So what they showed is that there's a very strong correlation between a short-term change in proteinuria and the long-term benefit that is seen on kidney function. So the main conclusion of this analysis is that, as I said, a short-term reduction in proteinuria can be used to monitor treatment response, and that this reduction in proteinuria infers a long-term benefit on kidney function. And as a result of this, proteinuria can now be used as a surrogate outcome measure in clinical trials, and it's accepted by various regulatory agencies, including the FDA in the United States, the EMA in Europe, and Health Canada in Canada. But one of the main issues that was left unknown was, is there a minimum duration in which you need to enter proteinuria remission in order for it to confer a protective benefit? Certainly the KHI analysis suggests the amount of proteinuria is important, but how long do you have to stay with low proteinuria before it confers a benefit? So to answer this question, we again went back to our international databases. We defined achieving remission as getting a proteinuria less than 1 gram per day. And you'll see that that threshold comes up later in the KDIGO guidelines for treatment. And our goal here was to determine if the duration of proteinuria remission is an important factor that determines long-term risk of disease progression. So what we actually demonstrated is that there was no minimum period of duration. Actually, every additional 3 months that is spent in remission is associated with sequentially lower risks of kidney function decline. So every 3 months add up over time to sequentially lower the risk of kidney progression. And so collectively, this literature suggests that the effective treatment on proteinuria can predict long-term benefit on kidney function. That KHI analysis suggests the amount of proteinuria reduction is very important. Our recent analysis suggests the duration of proteinuria remission is important, so that both of these sort of independently affect long-term kidney outcome. And it supports the use of proteinuria as a marker for treatment response over time. So why have I spent so much time going over this data? It's because this data explains why your physician may be so focused on repeatedly measuring proteinuria over time in order to monitor disease activity. We acknowledge that this is an inconvenient and time-consuming test to do, but the amount of information you get out of this test is extremely valuable in terms of understanding what's happening with disease activity over time. So I'd like to now talk about current treatment options in IgA nephropathy. So this is taken directly from the 2021 KDIGO guidelines. So in most patients with IgA nephropathy, as indicated up here at the top, they will start off with some form of conservative therapy. So most people would be managed through blood pressure control, use of medications like ACE inhibitors or ARBs, lifestyle modifications. So here I'm talking about salt restriction, weight loss, exercise. If a person has sleep apnea, using CPAP can lower proteinuria quite substantially by 30 or 40%. Quitting smoking, all of these things substantially lower proteinuria. But if proteinuria, according to the guidelines, is still greater than 1 gram per day, and kidney function is preserved, greater than 30, there's a recommendation that we consider discussing the risks and benefits of corticosteroids for the treatment of IgA nephropathy. Now, there are some populations that may benefit from other treatments, such as MMF, but today we're going to focus mostly on steroids. So this is the dosing regimen recommended for IgA nephropathy in the guidelines. It comes from several different clinical trials, but you can summarize them by saying that there's a period of high doses, which lasts approximately 2 months, and then the drug is tapered off over a total of 6 to 8 months. What was clear is that these drugs seem to be quite effective in terms of reducing the risk of kidney progression. The problem here, though, is that high doses of steroids equals lots of side effects. And so it wasn't clear if the side effect profile was really worth the cost of treatment. So with that in mind, I'd like to present some of the data on the testing trial that some of you may be aware of was presented in abstract format at ASN in 2021. So I'm grateful to Mujot Wong for these slides. This was presented by Vlado Perkovic. I would point out, though, that this paper has been accepted for a publication and will come out probably in the next few weeks in its full form. But this is the abstract data that is currently in the public domain. And so this was a clinical trial. It was a multi-center, multinational clinical trial that took patients, people with IgA nephropathy who had proteinuria over 1 gram per day, and randomized them to receive either methylprednisolone for 6 to 9 months or placebo, and they were followed long-term for the risk of kidney function decline. And this was defined in this trial as a 40% decrease in kidney function. Now, initially, this trial, much like the other trials, used higher doses of steroids. What happened, though, is that in 2015, the Data Safety Monitoring Board looked at the safety profile of what was going on in the treatment group. And what they found is that there was an unacceptable number of side effects in this high dose group. So as a result of this, the protocol changed. And it changed to then instead use a lower dose of steroids. So what we have now is a situation where some people entered the trial and got full dose steroids, and some people entered the trial later on and got lower dose steroids. So this is the primary outcome. So there was an average follow-up of 4 years. And now we're looking at the risk of a 40% decline in kidney function that was compared in the 2 different groups. And what we can see is that overall steroids substantially reduced the risk of kidney progression by around 50%. So this is a very large treatment effect in the steroid group. However, what's more important is that this was evaluated separately in the full dose and the low dose group. So in the full dose group, again, we saw this reduction of around 50%. But in the low dose group, we saw a similar reduction that was the same as what we saw in the full dose, meaning that you could use much lower doses of steroids and achieve the same efficacy in terms of lowering the risk of kidney progression. So what about side effects? So this slide here talks about serious adverse events, which would be side effects in the clinical trial. And certainly it was much higher overall in the steroid group compared to the placebo group. However, if you look at the distribution across the dosing regimens, you can see here that most of these side effects occurred in the high dose group, whereas very few side effects occurred here in the lower dose group. So in summary, what does this trial show? It shows that steroids really can be effective in lowering the risk of kidney function decline by around 50%, that high dose steroids, as we know, has substantial side effects. However, you can use the lower dose steroid regimen, which are equally effective, but have far fewer side effects. So going back to the KDIGO guidelines, we've talked about steroids down here and immunosuppressive therapies, but what about up here in terms of conservative therapy? Are there new treatments that we can use in IgA nephropathy that actually do not affect the immune system? So this is a subgroup analysis of a trial called the DAPA-CKD trial. The DAPA-CKD trial was not designed initially to be done in patients with IgA nephropathy. Instead, it was in patients with all-cause kidney disease who had a GFR between 25 to 75 and some degree of proteinuria. Now, importantly, they excluded patients from this trial who had recent exposures to immunosuppression. But they then randomized these people to people with all-cause CKD to dapagliflozin or placebo. So dapagliflozin is actually a diabetes medication in a class of drugs we call SGLT2 inhibitors. It turns out that you can give these medications very safely to people who do not have diabetes, and it doesn't lower blood sugar in these people, but there was a thought that it may actually protect and reduce the risk of CKD progression. So this was a very large trial. It included over 4,000 participants. And the primary outcome here was a 50% decline in kidney function or end-stage kidney disease. This analysis was done in the subgroup of 270 participants that just so happened to have IgA nephropathy who got into this study. So what they showed is that the risk of a 50% decline in kidney function was substantially reduced in the dapagliflozin group compared to placebo in patients who had IgA nephropathy in the study. So this is a very large treatment effect, and it's very impressive. What was unusual, though, is that the 2-year risk of progression shown here was around 16% in the placebo group. Now, this is extremely high and much higher than what we see in other cohorts with IgA nephropathy, because usually 2 years is so short that we don't see much in the way of disease progression over a short time frame. So this raises the question, well, what was the characteristics of the people that participated in this trial? Are they representative of the average person who is diagnosed with IgA nephropathy? So if we go and look at the baseline characteristics of the participants in this subgroup analysis, we can see that their average age was 50 to 52. Kidney function was around 43 to 44. Proteinuria was actually less than 1 gram per day. And actually 10 to 17% of these people actually had diabetes. Now, we don't have biopsy data in order to actually look at what the characteristics were at biopsy, which is quite unfortunate because that would be very informative to understand a little bit more about the characteristics of the participants in this subgroup analysis. But overall, you can look at these characteristics and you can say, well, this is a group that's a little bit older than your average cohort of people with IgA nephropathy. Kidney function is a little bit lower. Proteinuria is less than 1 gram per day. And this is suggestive that these may be people who have more chronic disease, more chronic IgA nephropathy, and perhaps a higher burden of scarring. And this is consistent with the fact that the study actually excluded people that were recently treated with immunosuppression. So it would have systematically excluded people with more active disease. So what's my personal approach to treatment in IgA nephropathy? So again, this is a personal opinion on my part that is a little bit different perhaps than the KDIGO guidelines. But first, I tend to optimize conservative therapy in almost everybody with IgA nephropathy that's newly diagnosed. So we're talking blood pressure control, ACE inhibition or angiotensin receptor blocker, salt restriction, smoking cessation, as I said, weight loss, exercise, treatment for OSA. All of these treatments can be very, very effective at substantially lowering proteinuria in IgA nephropathy. When I'm done that, after let's say 6 months or so, you then want to identify people who remain at high risk of progression and in whom you think they may respond to immunosuppression. So how do I do that? Well, I look at proteinuria. Is proteinuria greater than 1 gram per day still? Or alternatively, I look at their risk of disease progression from the prediction tool. I also look at features of active disease on their biopsy. Again, underscoring the need to have a good quality, relatively recent biopsy. Now, again, this is somewhat controversial. However, there's a suggestion in the literature that some type of lesions on a biopsy may respond to immunosuppression. I then discussed the risks versus benefits of lower dose steroids according to the testing trial protocol. I may consider MMF or Plaquenil as second-line options, but the evidence to support that is quite weak. And I do not personally routinely use tonsillectomy for the treatment of IgA nephropathy. And finally, if I identify people who remain at high risk of progression, but in whom I'm not going to give immunosuppression, then I consider what I call augmented conservative therapy. And that would be considering an SGLT2 inhibitor drug like dapagliflozin based on the study results that I showed previously. So let's talk about clinical trials in IgA nephropathy. So there are multiple new therapeutic targets that are being developed to treat this disease. So starting here with the inflammation in the gut, targeted release budesonide, which we'll talk about in some detail, directly addresses this part of the disease process. BAFF or APRIL inhibitors are also drugs that inhibit parts of the immune system that produce these IgA immune globulins, but also other drugs do similar mechanisms of action, such as proteasome inhibitors also inhibit antibody production. Now, hydroxychloroquine, which I alluded to previously, which is also called Plaquenil, also is thought to have a direct effect on the immune system that is active in the gut. Now, when you get these IgA complexes that deposit in the kidney, they tend to produce injury and inflammation through something called the complement system. And this is a very old rudimentary part of the immune system that tends to get activated from these IgA deposition. And so there are multiple different drugs that are targeting the complement system and inhibiting the complement system. So first, let's talk about targeted release budesonide. So these slides are courtesy of Jonathan Barrett, and we'll talk about his contributions a little bit later. But Nefecon is the previous name for targeted release budesonide. Budesonide is a steroid. It is put into these little spheres that are then put into a capsule. And the reason for that is it delays the absorption of budesonide when you swallow it down to the distal end of the small intestines or the very early part of the bowel. And this is where the immune system is present that we think produces these abnormal IgA antibodies that are part of the disease process of IgA nephropathy. Now, what's interesting is that all the blood from this area goes directly to the liver. And the liver does a very good job of metabolizing and removing all of the budesonide. So this drug might be affecting locally, but then it gets basically filtered out by the liver. So the rest of your body doesn't really see much in the way of steroids, which then reduces the side effect profile from steroids from this treatment. So there was a phase 2 study called the NephCure study, which recruited people with IgA nephropathy and randomized them to placebo or 2 different doses of targeted release budesonide. The systemic exposure to steroids was thought to be around 8 milligrams per day. So that's what gets through the liver and exposed to the rest of the body, which is actually a very low dose associated with very low side effect profile. So the treatment was given for 9 months, and then people were followed up to 12 months. And so this top slide shows proteinuria. And what you can see is that proteinuria didn't change much in the placebo group, but it tended to go down in the treatment group over 9 months. And impressively, it stayed low even after the drug was stopped out to 12 months. Also, they looked at GFR. So GFR in the treatment group tended to be quite stable and didn't decline, whereas there was a slight decline in kidney function in the placebo group. So even over a short-term trial like this, there was a difference in kidney function between the 2 groups. So as a result of this phase 2 trial, there was creation of a larger phase 3 trial called the NephCure trial. This is a long-term study, but the interim short-term analysis was presented at the World Congress of Nephrology in abstract format. And again, I'm thankful to Jonathan Barrett, who presented at World Congress for these slides. So this is the overall structure of the phase 3 study. So patients were randomized to Nefegon or placebo for around 9 months, and then followed up long-term here to demonstrate an impact on kidney function. However, what we have reported in the abstract format is the short-term effect on proteinuria after 199 participants had finished the initial 9 months of treatment. And so what we have here on the right is the results of the NefIgArd trial, and by comparison, results of the NefIgAN trial, which was that phase 2 study I presented in the previous slides. So in the phase 3 study, we saw proteinuria go down by around 30% in the treatment group compared to very small reduction in the placebo group. And this was very similar to what was seen in that previous phase 2 study. We also looked at GFR. So GFR really didn't change that much in the treatment group. However, it went down by around 7% in the placebo group for an absolute difference of around 4 mLs per minute between this group. That's over the short-term follow-up period. And that is the same effect that was seen previously in the NefIgArd trial. So now, as a result of this short-term reduction in proteinuria, the FDA has now approved, using an accelerated drug approval process, the first treatment now, targeted release budesonide, for the treatment of IgA nephropathy. So it's now called Tarpeo, that's the brand name of the drug, and it's approved for accelerated drug approval based on proteinuria reduction. Now, the trial does have to have ongoing follow-up to demonstrate that the drug also improves kidney function. If they fail to demonstrate the long-term effect on kidney function, the accelerated drug approval may actually be withdrawn. But this is obviously very exciting because this is a demonstration of using the KHI meta-analysis results and that support the short-term change in proteinuria as a surrogate marker to now get an expedited drug approval for the first drug approved to treat IgA nephropathy. And there's been a recent explosion in clinical trials in IgA nephropathy, and this has all really been made possible because of the KHI analysis that has allowed regulatory agencies to accept proteinuria as a surrogate outcome, which dramatically improves the feasibility and it reduces the costs, and it makes clinical trials much, much shorter. So the pharmaceutical industry is now far more interested in developing new treatments for IgA nephropathy. So if you go back in time in the last couple of decades and you look at high quality trials in IgA nephropathy, you really won't find too many. But more recently, there's been just an explosion of studies studying everything from complement inhibition, as I mentioned, the testing trial, the NefIgArd trial, plasma cell inhibition, as well as BAFF and APRIL inhibitors, and then even additional conservative therapies such as endothelin receptor antagonists. So with all of these trials out there, how do I approach clinical trial recruitment when I'm seeing people with IgA nephropathy? Because you might be sort of overwhelmed with all the different options. And so I take a step back and I ask, well, how would I treat this person with IgA nephropathy that's sitting in front of me in clinic? How would I treat them if there was no clinical trial to consider? What would I do under normal clinical practice? If I wouldn't consider immunosuppression at all, if I'd be looking at mostly just optimizing conservative therapy, then I would consider approaching that person and seeing whether they wanted to go into a trial studying augmented conservative therapy type treatments. And by that, I mean an endothelin receptor antagonist or perhaps antifibrotic agents, because generally these are lower risk treatments that can be added to what I would do anyways, which is the standard conservative care approach, and is a lower risk option for someone who would normally be treated with conservative treatment. However, if I would normally, to some degree, entertain the notion of immunosuppression for this person, then I may consider approaching them about a clinical trial that targets the immune system. And by that, I mean BAFF or APRIL inhibitors or complement inhibitors or plasma cell inhibitors. However, there's several important questions we need to ask when we're looking at a clinical trial and determining is it appropriate or not for someone with IgA nephropathy. The first is the duration of placebo acceptable given the risk profile for that individual patient? So if we use, for example, the prediction tool and we identify this person to be extremely high risk, we may not be very happy enrolling that person in a trial that has a very long placebo period because there may be an unacceptable risk that kidney function may decline during that time. However, if a study has a very short placebo period, that might be okay. We also asked the question, well, is there an open label treatment part? So if a person goes into the trial, is there some period of time in which they're guaranteed to get access to active drug? And we also ask, well, what's the side effect profile of the drug? Is it acceptable for that individual person? And we always have to remember that if the proteinuria does not respond during the trial, we can always consider treating with steroids when the trial is done. So it's not like we're taking steroids off the table. We're just simply perhaps delaying a decision on steroids to see if perhaps someone can get a benefit from being in a trial with a therapy that maybe has less side effects than corticosteroids. But fundamentally, participating in any kind of clinical trial involves some sort of altruism on the part of the person participating who is sacrificing their time and their energy, and to some degree exposing themselves to the risks of being treated with a new therapy in order to improve our scientific understanding of how to treat people with IgA nephropathy. And ultimately, it has the potential to improve people down the line who are diagnosed with IgA nephropathy in the future. For example, the FDA approval of Tarpeyo would have never been possible if it wasn't for the hundreds of people with IgA nephropathy that volunteered their time to be part of the NephGuard study. So finally, I'm going to finish by talking about COVID vaccines and IgA nephropathy. And just for the sake of time, we're going to talk about one specific question that I think might be particularly top of mind, which is, do COVID vaccines induce flares of glomerular diseases? So since COVID-19 vaccines were introduced, many of you may be aware that there have been isolated case report publications reporting people with glomerular disease that have had flares of their disease within a reasonably short time frame of being exposed to a COVID-19 vaccine. So a case report is when someone reports on an individual single case and describes what happened to that person in the period of time after getting a vaccine. Now, the problem with relying on this type of data is that all glomerular diseases, including IgA nephropathy, have an underlying relapse risk. So they have a risk of relapsing and flaring that is absolutely unrelated to a vaccine. So just because you find one person who relapsed very close to a vaccine, it doesn't mean that that flare would not have occurred anyways. Now, if you look at the case reports, the most common type of disease reported is actually IgA nephropathy. However, IgA nephropathy, as I mentioned, is actually one of the most common types of glomerular disease. So is it the fact that IgA nephropathy is just more common that explains why it's more represented in these case reports? Or is there something unique about IgA nephropathy that puts it at risk of flaring after a COVID-19 vaccine? And what these case reports also don't report on is all the multitude of patients with glomerular disease that got a COVID-19 vaccine and didn't flare. So they cannot generate an actual risk of disease flare after a vaccine that you can use to inform your decisions about whether you feel it's safe to proceed with the COVID-19 vaccine in the context of risks of disease flare. So with that in mind, we went back to our BCGN registry data, and we looked to study the risk of disease relapse after COVID-19 vaccine. Now, I would point out that this is currently unpublished data, so it has not gone through the full peer review process. So please keep that in mind. But in British Columbia, COVID-19 vaccines became first available on December 14th, 2020. So we identified all people in BC who had glomerular disease and who did not have a recent disease flare as of that date. We then followed all these people over time and looked at their vaccinations. And any disease flare that occurred within 30 days of a vaccine was attributed to be potentially related to that vaccine. When we did that, we identified a cohort of 1,100 people with glomerular disease, of whom 300 had IgA nephropathy. So we identified relapses based on lab data. So this was based on changes in GFR or changes in proteinuria. So the first thing you will note is that this will probably miss disease flares that might be, for example, asymptomatic gross hematuria that occurs after a vaccine, if that just goes away on its own within a few days and no one ever goes and gets blood work done. So it may miss these more mild flares that resolve on their own. But nonetheless, this figure here describes the actual relapse risk that is unrelated to a vaccine. So this is the relapses that are not related to vaccines at all. So what it demonstrates is, as I mentioned, these glomerular diseases tend to relapse over time. So this is most common in lupus nephritis, but also in IgA nephropathy, and all the way down to 6% relapse risk in membranous nephropathy. So it underscores the fact that relapses occur in glomerular disease unrelated to vaccines. So what is the risk related to a vaccine? Well, first, let's talk about the relative risk. So we looked at the relative risk of disease relapse in the 30 days after a vaccine. And it turns out that after the first dose of a vaccine, there was really no increased risk at all. But unfortunately, after the second or third dose, there does appear to be a twofold increased risk of disease flare. Now, there was no difference in this risk based on type of GN. So patients with IgA nephropathy were at no different risk of disease flare than any other type of glomerular disease. And there was also no difference in risk depending on the type of vaccine. However, I would point out that in BC, most of the vaccines used were mRNA-based vaccines with Pfizer or Moderna. There was very limited use of AstraZeneca vaccine. I would also point out, though, that 17% of these vaccine-induced relapses actually needed some change in immunosuppression, meaning that most of these flares went away on their own, and they were mild and easy to treat, and none of the people who had a flare needed a repeat kidney biopsy. Now, that being said, though, these results still don't give you the information you need when you're trying to make a decision about vaccination. What you really want to know is, what is my percent chance, increased risk of having a flare in the next 30 days after getting a vaccine? That's what's shown here on the left. And in this panel here for IgA nephropathy, you can see the increased risk in the 30 days after getting a vaccine after the first dose is shown in blue, and this is around 0. So there's really no increased risk. And what you can see in red is that the increased risk of getting a vaccine, of flaring after a vaccine is around 2 or 3% after the second dose. So it's a very small increased risk. So what does this data show? It shows that the first dose of vaccine does not seem to be associated with an increased risk of disease flare, but the second or third doses of vaccine, unfortunately, do have a small increased risk of flare, but the absolute risk is extremely small. It does, however, warrant more careful monitoring of your disease activity in the period of time after a second or third dose. Likely, the benefits of any vaccine far outweigh any risks. The absolute vast majority of people who get vaccinated with glomerular disease will not have a flare. Most flares after a vaccine resolve on their own or are easily treated. And the risk of flare is similar across all types of glomerular disease, and it's similar based on types of mRNA-based vaccines. So with that in mind, I'm going to stop there. I'd like to thank NephCure for inviting me to give a talk today. I look forward to a discussion. I'd like to thank my sources of research, funding and salary support, as well as my statistical and research team, as well as my Canadian and international investigators that have worked so hard in terms of pooling data to generate some of the novel results that I've been able to present today. So thank you very much.
Thank you so much, Dr. Barbour. This was absolutely perfect. So I do have some questions. Agnes asked a question. Who are the right candidates for steroids? Is it just based on the degree of proteinuria?
That is that's a very good question. And we don't necessarily know exactly which kind of person will individually respond to treatment. So if you go look at the testing trial and you wanted to apply those results to perhaps everybody, the testing trial just required having high proteinuria with preserved kidney function after a period 6 months of optimal conservative therapy. So you may extrapolate that data to everybody with IgA nephropathy. I would, however, provide my own personal opinion in this regard, which is that we need more research studying which kind of people individually respond to therapy. And this is where I think having a close biopsy to when you're making this decision is being very important. We are looking at studying the testing data to figure out whether biopsy features might respond to treatment, might indicate treatment response. But from what we have available now in the literature, there is a suggestion, but really no definitive proof, that people with more inflammatory type lesions on a biopsy are more likely to respond. So what do I mean by that? I mean, the terms we use are like mesangial hypocellularity or endocapillary hypocellularity, or maybe crescents on a biopsy. So these are complicated pathology terms that mean inflammation. There are certainly many people with IgA nephropathy that at the time of their biopsy have IgA nephropathy, but maybe that disease was active 10 or 15 years ago. And at the time the biopsy is done, really we're seeing IgA deposits, but mostly with scarring. And if it looks like it's post-inflammatory scarring, again, we don't know this for certain, but my personal opinion is I don't think that that would be a good person to consider the risks of steroids. I may consider more the augmented conservative therapy like the dapagliflozins, or maybe going into a trial studying endothelin receptor antagonists, for example.
Yeah, great. Another question for you. First of all, I have to say I'm fascinated by your predictor tool. I think that this is honestly could be totally revolutionary in the way that people really look at prediction of disease progression and how it can influence treatment options, including clinical trials. And I really appreciate what you have shared with us today. I'm curious it was obvious. So I'm a nurse by trade. And so it was clear to me that the predictor variables that you were using were obviously clinical outcome assessments, right? I'm curious if you have used or incorporated, throughout your research, have you incorporated any other type of variables such as like self-management ideas, patient activation or health literacy and that sort of thing as far as predicting disease progression and how that can, I don't know. I'm just curious what your thoughts are on that.
Yeah, so that's a good question, because when we did this research, we did it from, the physician's point of view in terms of what kind of data would a physician have available to help predict outcome with a patient. So again, the tool is really not well designed for patients to use. Now we are looking, we actually have a CIHR grant down the line to put this all together and try to create a more patient-friendly decision analysis tool to help guide this. At the current time, though, that really is not available. We did, however, do a small focus group session in Toronto, focus group of patients with IgA nephropathy. And, this issue came up in terms of, well, what can I do to modify my risk profile, right? What can I do? What if I change my diet? What if I lower my proteinuria? What if I improve my blood pressure? And so it became quite obvious that people with IgA nephropathy wanted to look at the tool and say, well, what can I do to improve my predicted risk? And that obviously is a very intuitive thing to think about, is that, well, I have this risk, what can I do to make it better? And that's why we pursued this line of trying to update the tool so it can be used later. So it doesn't directly include patient reported measures, because unfortunately the data sets we have just don't have that kind of data in it. But certainly the updated tool that will come out hopefully soon in Kidney International can be used after someone goes through a period of improving their lifestyle and reducing salt and weight loss and exercise, because we really should not underestimate how important these are in terms of reducing proteinuria. And I think I didn't present this here, but there was a study called the Stop IgA Nephropathy trial, which people may be familiar with. It was done in Germany. And they were extremely effective in the run-in period of this study of really aggressively implementing conservative therapy. And what this study is, one of the big takeaway messages from the study from me, is that there are so many people that improve during the run-in period that if you really aggressively implement those measures, you can lower proteinuria quite substantially.
That's really great information. So, if you were to, talking to the patient community, obviously through this webinar, what would you say? Obviously, this is probably be a personal, professional opinion, but what is the most important thing someone can do to protect their kidney function if they're diagnosed with IgA nephropathy?
Personally, I think salt restriction. Salt is evil. Salt will increase your proteinuria, even if you're on maximum RAS blockade. If you lower salt in conjunction with that, you can get an additional 30% reduction in kidney function. The other, so that's huge, right? That's a large benefit that is in addition to ACE inhibition, just by restricting salt. And it's very hard to lower salt because everything we buy has so much salt in it. Bread, beer, processed food, everything, a ton of salt. So it's very hard. And you need to put a lot of effort into a salt-restricted diet, but it can be very beneficial. The other avenue to pursue really is exercise and weight loss, because there is something about the kind of fat that is located in the tummy that produces a hemodynamic strain, like a pressure strain on the kidneys, and can increase protein in the urine. And in addition, if someone has gained weight around their neck, it can cause blockage when you sleep, and that's sleep apnea. So the combination of these can really, again, dramatically increase proteinuria and puts a huge strain on the kidney, so that exercise and weight loss, again, can dramatically lower proteinuria. And we see that all the time in clinic. When, the pandemic came, Canada was locked down, people became more sedentary. Unfortunately, DoorDash and ordering food, weight gain occurred and proteinuria went up, through a combination of high salt diets and weight gain. And so, really taking this opportunity to adopt the healthiest lifestyle you can consider adopting that matches what you're able to, implement, can really reduce proteinuria in the kidney.
Yeah, a lot of self-management,
Yeah.
what you were just talking about, what people can do themselves to help protect their kidney function and stop the progression of disease. So that's really important. One more question for you before we have to let you go. I know that we're just a couple minutes over time. I'm curious what your thoughts are about the likelihood that we're going to see like combination therapy, something like, the dapagliflozin type of combined with maybe another drug that could be still in clinical trial phasing right now. What are your thoughts around, do you think that might be a solution as far as, moving forward with IgAN treatment and stopping progression of disease?
I think that, as my slide showed, there's a lot of different treatments being studied. And, even if half of them prove to be effective, we're still going to be left with very substantial repertoire of treatments. Now, one of the challenges might be the cost of these drugs in terms of accessing them. One of the challenges I've struggled with dapagliflozin is that when you start it, the average age of diagnosis is around 30, in IgA nephropathy. And we're talking now a lifelong treatment, because when you stop the drug, you probably lose the benefit of it. So that becomes expensive and also very, very long term. So I think that we'll be moving towards a situation. If I was to predict, I would predict that we're going to have different drugs that target different aspects of the disease process. And we're going to be looking at secondary analyses of these studies to try to identify which patients might actually benefit from individual drugs. I mean, we need to, I think, get away from the concept that all people might benefit the same from a trial and move more towards individual personalized medicine approaches, where we try to identify whether an individual person that we're seeing in clinic may actually benefit from any one individual drug. And that will require substantial secondary analysis of the clinical trial data. But then maybe we might be able to do more refined treatment decisions and target certain therapies to people that we think might benefit on the background of perhaps better augmented conservative therapy.
Absolutely. Absolutely. Just to finish up, I just want to share, Diane has put in a couple of things in the chat. First of all, Diane, I will tell you that we did record this session and it will be uploaded to the NephCure website. I will send a link to the recording so that you can have access to it in the future. But Diane said, my nephrologist should watch this. I aggressively changed my diet on my own while he was recommending dialysis and improved her GFR by 8. It went from a GFR of 18 to 26 just by eating a very clean diet. She said, I think I'm going to find a new nephrologist. So, you know what, Diane, this is exactly why we do exactly this type of work, to try to educate and empower our patients, not only through knowledge, improving knowledge, but also empowering them to really look holistically at their life. And is the collaboration between their doctor truly collaborative? Because that's what we believe in. We believe that your doctor and you should actually work together to try to manage your disease the best way. So thanks for the comment. Dr. Barbour, thank you so much for your time today. I appreciate you going over a little bit with us to answer some questions. And I hope you have a wonderful day.
Thank you for inviting me. This is the first talk I've given to a patient group, so I was pretty excited to participate.
This is great. It's been really perfect. Thanks so much and have a wonderful day, everyone.